Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.
Welcome to Remission Possible, the podcast dedicated to guiding and supporting you on your mission to achieve lower disease activity. I'm your host, Adam Kegley, Associate Director of Global Partnerships at the Global Healthy Living Foundation. We understand that this challenge wasn't something you asked for, but remember, you are stronger than you think, and you deserve the opportunity to regain control and live your best life. In each episode, we'll share inspiring stories from patients who are succeeding in their mission and discuss how patients and doctors can work together to better understand the optimal course of treatment for different chronic conditions while keeping personal goals and lifestyle choices in mind. In today's episode, we'll have an open and honest conversation with a leading rheumatologist, Dr. Irene Blanco, who will share her perspective on what drives her to help lupus patients on their mission to feel their best. Dr. Irene Blanco is a professor in the Department of Medicine Rheumatology, Director of Lupus Clinical Services, and is the co-director for the Clinical Research Ethics and Equity Consultative Service, which is part of Northwestern University's Clinical and Translational Sciences Institute. At Northwestern Medicine, her research interests focus on health outcomes, health disparities, and adverse social determinants of health in rheumatology, and in particular, systemic lupus erythematosus. She is the current co-chair of the Diversity, Equity, and Inclusion Committee of the American College of Rheumatology, and serves on various DEI and health equity committees and task forces. Together, we'll explore how people living with lupus can work hand in hand with their doctors to prevent subpar treatment and establish a clear understanding of remission. So whether you're a patient in the early stages of your journey or someone looking for inspiration and motivation, this podcast is for you. So join us on this mission as we empower you with valuable insights and tips to break free from the cycle of pain and anxiety and ultimately bring you closer to achieving low disease activity. It's time to rewrite your story because remission is possible. Hi, Dr. Blanco. Thank you so much for joining us today.
Hi, thanks so much for having me.
Of course. And I was just wondering to start, if you could start by introducing yourself briefly to our listeners and telling us how you came to focus on lupus specifically.
Sure. So my name is Dr. Irene Blanco, and again, I'm the Director of Lupus Clinical Services at Northwestern here in Chicago, Illinois. So how did I focus on lupus? So lupus is a disease that predominantly affects women, and in particular women of color. And being a Hispanic woman myself, I think it hits a little close to home. And so I actually have an aunt with lupus. And growing up, I had seen my aunt with lupus, but it was somewhat of an abstract. You saw her that she was sick and she has significant arthritis, a lot of joint deformities and whatnot, but she didn't really know what lupus was. And where I went to medical school, it was in a place where there was a very high prevalence of lupus. And so I was actually really exposed to lupus in medical school, which is not necessarily common. A lot of medical schools actually don't have rheumatology courses. And so many medical students don't really get a good education in rheumatology and in lupus. But I was very lucky to actually have a really good experience and have a lot of exposure early. And so seeing so many lupus patients early on, it just really made such a huge impact and really imprinted on me sort of like the myriad of disease presentations, really just what patients go through. And I think as a doctor and a provider, like what we can do to really help patients. And I think, as a young woman myself, very much in that age range, right? Because when you're a medical student, you're in your early to mid 20s, you see yourself in your patients. And it really made an impact on me, and it's kind of set my career in motion.
That's fantastic. Thank you so much for the background, Dr. Blanco. I think it's really interesting that you have, from your personal history and professional history, history kind of combined to bring you into lupus. And it's, I think, something that you mentioned really stood out to me is that patients sometimes don't even really realize what the disease is that they're living with. I think you mentioned that your aunt really didn't know specifically what lupus was. Is that correct?
Lupus is a rare disease, right? So I think
Yes.
there's not a lot of dialogue in communities on what lupus is, just generally.
Yes.
It's not as prevalent as diabetes or high blood pressure. So everyone knows somebody with diabetes. Everybody knows someone with high blood pressure. You get to a certain age and everybody sits around and starts comparing their medicines, right? All the grandparents sit together, all the aunties sit together. It's like, what are you on? What are you on? Oh, I take that for my cholesterol. Oh, do you like that one? I take this for my cholesterol, right? But like when it comes to rare diseases, people don't know what they are. People start looking things up online. And let's be honest, I predate Google.
From the Ask Jeeves era.
I even predate that. There was not much information. So there's a lot of misinformation. So it was very hard for people to even know or understand. And then when you even think about the immune system, that in and of itself is a very hard topic to understand. Baseline, even for physicians and other allied health professionals. So for professionals, it's hard to understand. Nevertheless, for like a layperson, it can be really challenging for then a patient to describe to their family members, their partners, etc., what they have, what exactly is happening to them, especially oftentimes many lupus patients don't really have the rashes, don't really have a lot of the external signs and symptoms of lupus. So then it can become the situation where on the outside, people look at them and say, well, you look fine. There's nothing wrong with you. Like, I don't get it. And that can be really isolating.
Exactly. That's something that I think we've seen many times with other chronic conditions as well that are more on the rare side of things. Even something though like rheumatoid arthritis, sometimes people don't understand what that is, what the difference is between that and osteoarthritis. And I think the conversation becomes even more complex when you're trying to have a conversation with somebody who may have systemic lupus erythematosus or SLE and trying to define remission and what remission might mean to them or low disease activity. And I wonder if you could explain your perspective here, how you kind of try and explain that to someone who is maybe newly diagnosed, maybe not, that remission that is, and also tell us if maybe remission is even talked about often in SLE.
I think we're talking about it a lot more. I think the dialogue was really, the bar was really set by rheumatoid arthritis, right? This idea of treat to target. So the dialogue started with RA, and I think we really started to pick up that lexicon and to start using that verbiage in lupus a little bit later. It wasn't until later with the definition of like DORIS remission and LDAS, which is like low lupus disease activity, where we now have like goals. Because I think for a really long time, we all set the bar a little differently as to like what remission looks like and what low disease activity look like. I think now that it's really been defined by certain groups, we can now really set standards and really say, okay, no, this is how we're going to define remission. This is how we're going to define low disease activity. And now let's start being aggressive to get people there. Lupus is, and my favorite word for lupus, and actually I can't take credit for this because one of my favorite people on earth, who is a rheumatologist in Brazil, Catarina Villa, she's the one that first said it. Like we were just like talking one day and I'm like, yes, thank you. She described lupus as kaleidoscopic. And that's like the best word for it, like the best word.
Yeah.
Because literally lupus can affect every single organ system.
Right.
Literally every single one. And within each organ system, it can have a whole bunch of different manifestations. And so not any one patient can present in any one different way, right? So even in lupus nephritis, there's a whole bunch of different manifestations and you break it up in different classes of lupus nephritis. So even like patient A can have class 4 lupus nephritis and patient B can have class 4 lupus nephritis, but that doesn't mean that patient A and B will respond the same way to the same medicines. So it's very, very different. So now if we sort of define remission in the same way and we're like, okay, well, these are our targets. and we're going to treat to target. And these are our definitions. And we know that potentially they're not going to respond the same way. Well, at least we now have an endpoint and an end goal. And now we know, all right, well, these are our reassessment points, and this is what we're going to go towards. So we may take a different path for each patient to get there, but at least we know where our goal is, right? We know where our target is.
Exactly. And I think that's a really good point that the journey for one patient might be radically different than it is for the next.
Totally.
And I think you talked about this a bit in your response just now, but I was wondering, do you have kind of those specific measures that you use to assess remission in patients or when you're planning treatment strategies for them?
Yeah. So, I mean, the remission targets that we talk about is the DORIS remission target.
Okay.
So, DORIS remission is defined as a SLEDAI or SLE disease activity index of 0. So, a clinical SLEDAI of 0, right? So, no disease activity index clinically. They may have potentially some disease activity in terms of their labs, but clinically, there's no arthritis, there's no rash. Like clinically, everything is quiet. Their physician global assessment, so what the physician sees, it's on a visual analog scale. So it's at less than 0.5. So it's pretty much 0. They're at less than or equal to 5 milligrams of prednisone. So they're at a stable, really low dose of prednisone, and they're on stable immunosuppression. We may not always be able to get our patients off immunosuppression. Just like patients with high blood pressure, they have nice low blood pressure because they're on high blood pressure medicine.
Yep.
It is what it is. We got to keep this disease quiet to keep them healthy, to keep these organs working well, to keep long-term outcomes looking good and healthy, to keep them being able to have happy, healthy, functioning lives. And that means potentially maintaining long-term immunosuppression. Potentially, we might be able to taper down the dose of the immunosuppression, but oftentimes we are not able to take it off completely. And it is what it is. So in the DORIS remission criteria, the idea is that we get you on a stable dose and potentially we leave you there with the idea of if we can taper it, awesome. If we can taper it to off, fantastic. But more often than not, we're probably getting you to as low a dose as possible and probably leaving you there.
And I was wondering if you have any advice for kind of those key questions that patients might be asking their doctor, should ask their doctor regarding that end goal of achieving remission in lupus.
I think it's important that patients are aware of sort of like the numbers of lupus, to kind of be a little savvy of their lab numbers. Now that a lot of the electronic medical records start to show patients their lab numbers, for better, for worse. I'm not necessarily incredibly keen on the lab just like automatically releasing to the patients within like 2 minutes of the labs being drawn, right? Sometimes I'm like, give me a few minutes to review the lab.
Before you get 10 messages.
Before I get 10 messages, because odds are the patients didn't go to medical school. And so sometimes it could be a little hard for them to interpret. And they're like, I don't know what I'm looking at. And I'm like, how would you? You didn't go to medical school. You're not a PA. You're not an MP. Like, you don't know what the heck you're looking at. Like, no, I get it. Totally. But there is a benefit in it, right? And I think for a long-term patient, this is a chronic disease. If you start to learn that in your lupus is very responsive to your complement levels. So when you're active, your complement levels tend to drop. And when you're not active, your complement levels tend to go up. So you're starting to feel kind of sick and you tend to get your labs a week or two before you go see your doctor. And sure enough, you see your labs come back and your complements are a little lower. And you're like, yeah, that tracks. You're like, sure enough. So when you see your doctor, you're like, you know what? I haven't been feeling so great. And I saw my complements and they're a little lower. And I think I'm heading into a flare. That's a better conversation than you're having with your doctor. Or if you know that when your lupus is more active, that your platelets tend to go down and you starting to see that trend and your platelets are starting to go down, maybe we're starting to catch it early before your platelets really, really drop and we have to hospitalize you. So I think being savvy about your labs, if you have lupus kidney disease, knowing what your protein in the urine is, knowing what your serum creatinine is, etc., because that helps you to have better conversations with your rheumatologist, with your nephrologist or kidney doctor. And it helps you to sort of have an understanding long term, because if, heaven forbid, we start to have discussions about things like transplants, things are not a surprise.
Exactly. And I think it's a really good point too that you make, is that with all of the information about blood work, if people don't know what those particular items are, they can also ask those questions as a pre-questions almost to their doctor.
Oh, yeah,
And you can explain those things, and then that way they know what to look out for.
exactly.
I think it's really, really important. I know that some of the work you're doing on the research side also, of course, directly feeds into this. And what we talked about earlier about how lupus is especially prevalent in women and especially prevalent in women of color. And I wanted to talk about that a bit, about your research, because it's really important. I know it's focused on health disparities, but I was wondering if you could tell us about some of the findings from your research about health disparities specifically for lupus patients.
Lupus disproportionately affect patients of color, both on men and women, and it's generally across all racial and ethnic groups. And it's not only a situation where it's tied to racial and ethnic minorities, but there's also a large prevalence in communities affected by poverty and also disproportionately affected by adverse social determinants of health. So what is it about just the adverse environmental, psychosocial issues that potentially lead to derangements of the immune system that within the right background can lead to this downstream effect that potentially can lead to lupus? So we see, for example, that in patients with higher economic instability, for example, they have higher disease outcomes, they have a lot higher disease activity index, etc. They have poor access to care, all the things you can imagine. My research really focuses on thinking about how we actually teach our providers and our trainees on really addressing those things within clinical encounters and how to really start talking to their patients about doing something.
Right.
Like how they can start to address it with their patients to move the needle forward. Because we know, like our data shows, that particularly our trainees are very overwhelmed by all the psychosocial issues that they see our patients facing. Because when you go to medical school, you learn all about the molecules of a disease. You learn about the cells, you learn about the molecules, you learn about the drugs, you learn about all the things. But you don't really think all about the psychosocial things that a patient goes through. Oftentimes, that's sort of talked about in a way that's like, oh, well, that's what the social worker does. That's what the other people, quote unquote, in the hospital or on the team think about, focus, and do.
Right.
But that's BS. Because at the end of the day, you're going to be that patient's doctor for many years. And if you're not addressing it, you're not sort of like in it with them, you can't deal with it one-on-one with the patient because it's really affecting the one-on-one care that you're delivering with your patient.
Exactly.
You have to know, at least be aware of what the patient is facing to be able to battle these issues, whether it's insurance issues, whether it's food insecurity, whether it's access, whether it's transportation, whatever's facing the patient. And so our trainees are telling us that their programs, their medical schools are not teaching them how to do these things. Their residencies are not teaching them how to do these things. Their fellowships are not teaching them how to do these things. And then they go out into practice, and most rheumatology practices don't have social workers, don't have psychosocial support. And then the patients are like, I can't get my meds. I have no transportation. I have no this. I have no that. And then we wonder why they're flaring.
Exactly. It's a really good point, and I think it also speaks to the need for someone to be able to address all of those issues holistically, because there is also a certain level of distrust or mistrust amongst certain underrepresented communities when it comes to the healthcare system and when it comes to healthcare providers in general. And I think what you're saying and what your research is aiming to do, if I'm understanding correctly, is also addressing that too. and really tackling those things. I think all of these things kind of apply. Are these things you're actively doing in your practice to help patients overcome disparities in care in that regard?
Definitely. So, I mean, I think, in terms of what I've done at my prior institution and what we're doing here is to be incredibly proactive about thinking about our patients very holistically and the issues that they're facing. And to really say, we're going to take every individual that we have in front of us, as you say, like holistically, and thinking about them as a whole person and not really taking their disease as if it's separate from the person. Like, this is a person with lupus. It's not like a lupus case, as if it's like just a case in a vacuum, right? It's attached to a person that has a family, that has a job, a life, goes to school, has all the good and the bad and everything that comes with having a life. And you can't separate those things.
No.
And if you don't necessarily work with your patients and really think about their context, you're not really delivering care. And we really need to work within those frameworks and those constructs to be able to really think about that. So how do we deliver multidisciplinary care? How do we coordinate care across different disciplines to be more streamlined? How do we really think about increasing our access? How do we facilitate, for example, care for our limited English proficiency patients?
Exactly.
How do we ensure that we have sufficient resources, like within the clinic, as well as like through the NM community, to help support those patients when they face their adverse social determinants of health? Are we collecting their social determinants of health so we can understand who's facing food insecurity, housing insecurity, et cetera, so we can start to leverage the broader institutional resources that we have and start to plug them in and actually be proactive? Because I think you feel so helpless when you don't have the tools to help take care of your patients. But when you realize that so many of these efforts are actually in existence at the hospital, they just may exist within primary care or they may exist in general internal medicine, but they exist. How do we then start to plug in and start to leverage these other resources and then start to partner across the institution? It ends up saving the institution money because potentially we may subsequently avoid ER visits, hospitalizations, etc. But also it just takes better care of patients.
Exactly. This conversation has been fantastic, and I don't really want it to end. I know for one thing that if I had lupus, I would definitely be calling you up.
Thank you.
Or anybody that you recommended for that matter. And I think too, just as a last thought, thinking about everything that you've said, if you could condense all of your thoughts and advice for patients into kind of 3 words or short phrase you would share with them listening, especially those who might still be in an early stage of their journey, just to support them in continuing onward to seek the best possible treatment, what might those 3 words be?
3 words.
Or a phrase.
Don't give up.
Exactly. What was it that your doctor friend from Brazil said?
Lupus is kaleidoscopic.
Yeah, kaleidoscopic as well. Very interesting.
It's the best word. It's the best word for lupus because it really is. I mean, I think that's the phrase. Like, it's don't give up, because there's going to be days that are going to be incredibly hard. And there's going to be some very high highs and they're going to be some very low lows. I think what I tell patients, particularly in the beginning, right at the beginning when they're first diagnosed, is that the beginning, particularly the first sort of like 6 months, maybe even the first year, can be really, really rocky. Potentially there may be multiple hospitalizations if they have significant organ damage, etc. They may be on really potent medications. They may be on infusions. It could be really, really scary, and just like they may be interacting with hospital systems in ways that they never thought about or even expected, especially if they're very young. So they may have gone from never being sick to now all of a sudden being really, really sick. And that could be incredibly traumatic. But it's really to understand sort of like that we're with you, that like we're part of your team. And the biggest thing is to like not give up. And that if things are starting to feel sort of like dark and hard, to let us know. We're here for you, and that we can help you find the resources that you need. And taking care of yourself is not only taking care of your body, it's also taking care of your mental health, because it is so hard. It is so hard to be sick. And it is so hard to be sick with a disease that literally can affect every organ system. And lupus patients can get insanely sick very, very quickly. So you may present needing dialysis. You may present with new strokes. You may present in heart failure. You may present really, really ill. And if you're 19 and you never thought that anything like this was going to happen to you, you were a college student and now you're on dialysis, what the heck happened? That could be so traumatic. We're here to help you through all of that and to let us know. And we can it can be really rough. It can be incredibly hard, but to let us know so that we can help not only the physical side, but also the mental and the psychosocial side.
I think that's quite perfect. I think you had 3 phrases actually that were 3 words each, which was don't give up, we're with you, and let us know. And I think that really beautifully sums it up. And I just wanted to thank you so much for your time and for being with us today. I think it's really going to be hugely beneficial for patients to hear you, and you might be getting some phone calls.
Awesome. Thank you.
Thank you for joining us on Remission Possible, the podcast where we explore the path to low disease activity and improved well-being. We hope the stories, insights, and guidance we've shared have inspired and empowered you along the way. This podcast was made possible with support from AstraZeneca. If you like what you've heard, be sure to rate our podcast, write a positive review, and spread the word by sharing with your friends and family. It'll help more people like you find us.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.